Now, in the past, the risks of HRT were emphasized and the benefits were underplayed. And I know a lot of this information is still around. Can you tell us a bit more about this and perhaps put it into perspective?
Now, the explicit risks of estrogen depend on what type of estrogen you're taking. And the same is true for progesterone. So we know from those older studies, which caused the scares, particularly in the early 2000s, where the media were frankly irresponsible in the way that they reported this data, um, but it stuck, unfortunately, was that those risks have since been proven not to be the case. So everybody worries about breast cancer. You're much more likely to be at risk of breast cancer if you're overweight, obese, drink more than 2 or 3 units a day on a regular basis. And in actual fact, the natural estrogen, so the body identical estrogen that we replace through the skin in the licensed transdermal preparations that we use are shown to not increase risk of breast cancer. So I think we've got to be very clear about the evidence and to make sure we're looking at the latest evidence and the relevant products. There's no increased risk of blood clotting beyond the woman's natural risk of blood clots if she's using transdermal estrogen. There is an increased risk from taking oral estrogens, and in modern practice, unless there is a particular reason why we need to use an oral HRT product, we don't start there. We start with the transdermal neutral risk for blood clots estrogen replacement, and that works very well for the majority of women. And I think all of these risks need to be offset against the benefits that we can see and have been proven to be there for HRT.
Mm, mm. And is it true that women on HRT who develop breast cancer have better outcomes?
Women, there's evidence to show that women that get breast cancer when they're on HRT, and indeed we will get women who get breast cancer when they're on HRT, just as we will get women not on HRT getting breast cancer. It's a very common form of cancer. But the evidence shows that women on HRT have a lower death rate from their breast cancer than women who don't. We also know that women who don't take progesterone as part of their combined HRT, because they no longer have a uterus, so they don't require the uterine protection that the progesterone gives them, women who take estrogen only have an equal or better breast cancer rate than women who are not on HRT at all. So that rather suggests, and the hypothesis at the moment is that it's the synthetic progestogens that are leading to a potential increased risk in breast cancer. But like anything, the evidence varies depending on where you look and how the trials have been designed. It's very difficult to do retrospective studies on an equivalent population. And so evidence will continue to emerge, and our thinking is continuing to grow. But if we think about hormone replacement as replacing the hormones that women now don't make, so we're only replacing people to levels either just below or where they would have been throughout their natural reproductive life. We're doing it with the same molecular structure as the molecules that they made themselves. And so it makes sense actually for there to be very little increased risk associated with HRT.
Useful to know. I wonder, can you put some numbers to the benefits of HRT that you talked about earlier?
So, in terms of the benefits of HRT, the data is suggesting that HRT reduces the risk of osteoporosis by between 26 and 37%, reduces the risk of diabetes by 30%, reduces the risk of coronary heart disease by 50%, reduces risk of dementia by between 22 and 32%, reduces the risk of age-related macular degeneration by a third, and reduces the risk of depression by 50% and all-cause mortality by 30%. So I think the comment that maybe all women should be considered for HRT. The default should be HRT rather than sort of really need it. I think what I'm trying to say is women should be offered HRT unless there's a good reason not to go on it, just based on the longevity and the health benefits long term.
Impressive figures. Now, there may be some people who think they're too old for HRT. What can you say to them?
It's a really important point. We know from the data that the long-term health benefits can be best achieved if you start HRT earlier. And actually, the sooner the better. So any myth that exists that you can only have it for 5 years, we're going to dispel right here, right now. So it's really important to recognize that if you need hormone replacement, then the earlier you start, the better for your long-term health. However, there are women who can benefit from being on HRT. And again, it's about that individual in front of you, personalizing her care, evaluating the risks versus the benefits. But I've started women in their 70s on HRT and they haven't looked back. One poor woman was experiencing paralyzing night sweats. She was having to change the sheets every single morning for the last 22 years. And nobody had suggested she went on HRT. So we've popped her on HRT and she says she says she's never going to come off it, but she said it's absolutely been the best decision for her health that she could have made. And she's living a normal life, not to mention the other symptoms that are gone. So no, there is, as long as we look at that individual in the same way that we would for anybody at any age, then certainly age is not a contraindication.
And what can you offer in your clinic?
So here at Remedi Health, we really pride ourselves on listening to our women when they come in. And it may be that they presented for something completely different. So just this morning, I had a woman in her early 60s who has had worsening IBS symptoms. And of course, there are many things that can affect IBS, ranging from stress to different aspects of gut health. And so, as we explored that, I asked her if she was experiencing any other symptoms which she may not feel were particularly related to her IBS. And she talked about her night sweats and how these have started just recently. So she felt she was long through the menopause. And so she was concerned about these night sweats and then exploring further extreme joint and pain and aches, which is very common. And it's not unusual for someone to experience symptoms after their menopause. And so, some women go through perimenopause without too many problems, but then it's when their hormones are really low that they suffer. So, in that particular situation, she presented for something else, but by just listening and asking the questions and looking at a woman's health through the lens of her hormones makes us perhaps make some connections that she hasn't done already. But the key aspect of our service is listening. And so our initial menopause consultations will last up to an hour. And during that time, we go through a questionnaire process so that she has the opportunity to reflect on a wide range of symptoms. And that questionnaire, by the way, we repeat every time we follow up and review that woman so that we can see what progress has been made, what symptoms might be remaining. We do offer a full phlebotomy service. It's not always the case that blood tests for hormones are indicated, but sometimes they are. And so in that case, we can do hormone blood tests. But it may be during the history taking that we've uncovered perhaps something else that we might think is going on. For example, an underactive thyroid or autoimmune diseases, etc., in which case we can do broader blood tests based on that history. But during the consultation, we understand everything that's gone on. I'll do a full gynecological and obstetric history, as well as previous medical history, understand, of course, any medicines that she may be on, either prescribed or otherwise, supplements, etc. We explore lifestyle because we take very much a holistic approach that whilst it is frequently the case that a woman requires hormones to address her symptoms and certainly her long-term health, other things such as alcohol, weight, exercise, managing stress, looking at relationships, those kind of things is also fundamental. So we'll do an initial consultation that usually results in prescribing and supplying hormone replacement therapy in line with the guidelines. And then we review that woman at 2 to 3 months. So she'll come in for another half an hour. We go through any tweaks in treatment that need to happen. And it is frequently the case, Christine, that we do need to address different levels of hormones. You know, it may be that she's had some improvements, but other symptoms haven't yet gone. So we can adjust dosing to make sure that we tailor the approach to that particular woman. We're all different. You and I could be on the same hormone replacement therapy transdermally, but have a 10-fold difference in the amount that we absorb. And that's not even taking our genomics into account in terms of how we're metabolizing and processing that once it's in our body. So we need to take a very personalized approach. Having done that first review, depending on how she's getting on, we could potentially leave her until her annual review, repeating her medicines every quarter.